Everybody, it gives me great pleasure, enormous pleasure, to invite Wim. So Wim, if you could come up there, who has been a tutor, a colleague, and a friend of over 20 years. Okay, so it's great pleasure to have Wim here with us. Professor Wim Van Damme is Professor in Public Health with a focus on international health policies at ITM Antwerp. He's teaching public health to the MPH students and at the Paris School of International Affairs. His fields of specialization are health service organization and health policy. He has been the principal investigator of different research projects in countries as far apart as Cambodia and China and South Africa. He has looked at the impact of new international funding mechanisms on national health policies. He coaches PhD students from Asia and Africa and is an advisor to the Belgian Development Corporation on issues related to international health policy. He is the vice chair of the Technical Evaluation Reference Group of the Global Fund and has previously worked for 12 years in the field with MSF in countries as far apart as Peru, Sudan, Guinea, and Cambodia. So, that's Wim Van Damme. Welcome, Wim.
Okay. Yeah. Okay. Thank you for this opportunity to give a keynote speech. Although I'm not really an expert in health equity, certainly much less than many of the other speakers. I've done work on out-of-pocket expenditure and catastrophic expenditure and how poverty is often a side effect of access to modern medicine, which we have called iatrogenic poverty. So don't expect a real keynote, rather some random thoughts on health equity of somebody already working some 30 years in public health around the globe. So many of you know, I think, this fantastic book, The Health Gap, by Michael Mormont, which shows very clearly that health inequities are absolutely universal, also in rich countries and strikingly so in the richest countries in the world like the US and the UK. The subtitle is The Challenge of an Unequal World. And that is very important. Socioeconomic inequalities are really increasing everywhere in the world, as Thomas Piketty has very clearly shown with his book Capital in the 21st Century, even in countries in Western Europe where 30, 40, even 50% of GDP is captured as taxes. Inequity is increasing even faster in emerging economies as in India. So it is no surprise that health inequities are also universal. But our societies seem to be more tolerant for wealth and income inequalities than they are for health inequalities. So we have to think how in this increasingly unequal world we can reduce health inequalities. But if we don't tackle the overall income and wealth inequalities, it will be an uphill struggle. So it's absolutely necessary that beyond all we discuss here, there is much more attention for fair taxation, to tax the better off in all possible ways, so that there is enough public budget for redistribution and to pay for health and education policies, which are all in all mostly redistributive. Nobody accepts that market forces alone would determine access to healthcare or to education. But these policies need absolutely more public resources. Now, about the random thoughts, I first will focus on 3 aspects. The first is the scale of comparison we use when we discuss health inequities. The second is a bit beyond the most classical socioeconomic status and gender. And then third, about the time perspective we use when we try to tackle health inequities. So the first is the scale of comparison we use. We can look at a very large scale or smaller on smaller scales. Sorry. Okay. So usually we consider rich and poor or gender inequities, but at which scale do we use these comparisons? If you compare the rich in New York with the poor in a rural village in India, you will find, of course, huge inequities. Or if you compare countries, or you compare, like in India, between states or between districts or between cities or within villages, and sometimes I have the impression that some micro differences within villages get more attention than the huge differences between countries or in the world. And sometimes it goes very extreme that we say which are the richest people in an extremely poor village, and then we focus on that. So I think we have always to keep things a bit in perspective. And also which, as we say, we are in an unequal world, so which differences do we think are acceptable? Or do we really want a totally equal world, knowing that wealth and income are hugely inequitable? And which scale that we use is then rather fair or unfair? Because that's the basis, I think, of inequities. There are many inequalities, but which one do we consider unfair and vulnerable for action? The second thought is on the determinants of inequity. Sometimes this acronym is used, PROGRESS. So it considers all the most often considered determinants of inequity: rural, urban, race, ethnicity or tribal group, occupation, gender, religion, level of education, socio and economic status. Poverty, usually we consider income, but wealth is often more determinant. More recently, social capital has been added, but we can continue and add many S's to this list, like sexual orientation gets in the West certainly now lots of attention, or people with stigmatized diseases like HIV, or mental disease, or a specific focus on slum areas, or what is very important and not so often studied is people who live in split families, migrants, refugees, and people who are really not even living in a household but are completely on their own. More attention in the West for senior citizens, and all these dimensions, of course, are interrelated. So if you add them up, like a poor woman in a marginalized village with HIV or a mental disorder, then you go really for the most excluded of all. And so I think we have really to think very much beyond the classic, easily measurable inequities, which are gender and socioeconomic status, but there are many other factors which are much more difficult to measure or even to recognize, like sexual orientation or stigmatized disease for many people, but which are equally or more important, or where the health inequities are often huge. The third point I want to mention is a bit time perspective. If we want to reduce health inequities, we can be a bit impatient and want to reduce them in the short term, then we will go for quick wins, like setting up some additional vaccination program for the most marginalized, difficult to reach. And that is often what is within the scope of a development project or a project cycle for an NGO. But if we want to have a bit a longer term scope, we are able sometimes to address a bit more fundamental determinants of inequity, but then we need more time, 5-10 years, and then we can think of extending primary health care to unserved areas, for instance. But if really we want to tackle inequities more fundamentally, we will need many more years, 20, 30 years, often a generation. And that's also the title that Michael Mormott used in the article he authored in the Lancet, closing the gap in a generation. If we really want to do something fundamental for health equity, we have to take that time perspective, which is very difficult for activists who have much shorter time frames usually, also for governments who have also time frames of 4 or 5 years rather than 20 or 30, but that is really the way we should be thinking. Now, does this mean that we cannot tackle health inequities? I think we have really to think in a three-pronged time perspective. If there are quick wins, that's good to deal with it, but at the same time, we should be tackling more long-term and certainly also the longer-term determinants. That's not so easy, but I think we have to keep these three time perspectives always in mind. Otherwise, we are always continuously chasing some quick wins, which don't change much fundamentally in the long term. Another reflection I would like to have as researchers very often, and we have heard it often here also, more research is needed when we think about equity impact of policies. But is that really so? I think certainly more analysis of available data, routine data, and so is useful, but often research is not so needed. If you just give an example of something I'm pretty sure that will come up quite soon, there is now a big concern for antimicrobial resistance. India is seen as the hotbed of antimicrobial resistance in the world. So there will be calls for people, oh, the antibiotic should not be available anymore over the counter. It should be on prescription of a qualified doctor. Well, do we need an equity analysis to know what will happen? It will dramatically reduce the needed access to antibiotics for poor people. It doesn't mean this measure is not necessary. It can become necessary at a certain moment, but the equity impact is so obvious at first sight. You don't need research for that. And other issues, maybe a more contentious example, if you decide as a policy to ensure reimbursement of hospital expenses, that is sure that it is a very regressive policy. Access to hospitals for poor people is far, far lower than for rich people. So you can, of course, study what exactly is the equity impact, but it is obvious. Now, as a kind of a conclusion, I would want to postulate something, and I would say if a health policy, or any policy for that matter, does not consider equity explicitly, it is most likely going to increase inequity. We could phrase this as the inverse equity law, that it is almost invariably so. Now, but I would want to expand on that. If a health policy or another policy does explicitly consider equity, then we can hope it does not increase inequity, or it may reverse it. but then it is most likely that it will increase inequity in dimensions of equity that were not explicitly considered or within subgroups. So this means that tackling inequity is absolutely a never-ending story. We will always see new inequities emerging and new needs to intervene. Should we be discouraged by that? I don't think so. I think what is quite appropriate here is the quote of Nelson Mandela, who said, after climbing a great hill, one only finds that there are many more hills to climb. And that is what I wanted to conclude around inequity. And then this as a kind of introduction to 3 presentations. One of them explicitly tackles equity, the 2 others much less explicitly, but it is obvious from the discussion, I hope from the presentations also, that equity is an important underlying concern, and I think we can discuss that afterwards. So who you will introduce? Thank you.
Yeah. Thank you so much, Wim.